So we're going to move on to the beginning of our webinar, Cancer Basics, and it is going to be led by Dr. Melinda Telli, who is from Stanford University School of Medicine. And Dr. Telli is a big fan of FORCE, and we're a big fan of hers. She is devoted to clinical investigation in breast cancer, particularly focusing on early disease. She received her undergraduate from the University of Pennsylvania and medical degree from George Washington University with distinction. She completed her internship and residency at Stanford University and then stayed at Stanford to pursue fellowship training in medical oncology. And she's currently the assistant professor of medicine in the Division of Medical Oncology at Stanford with a clinical and research focus on breast cancer. So I'm going to let Dr. Telli take over now, if you'll bear with us while we switch over to Dr. Telli.
Okay, can everyone see my screen?
I don't think they can answer, so I can see your
but
screen.
you guys can see, okay. So, okay, I'm just going to move this over. Okay, so thank you all for coming and joining in on the webinar. It's a really nice big group of people, which is fantastic. Happy that you're all here. What I'm going to do over the next 45 minutes or so is just to go through some basic information about cancer etiology, what causes cancer, how suspected cancer is diagnosed and evaluated, and then I'm going to talk a little bit about treatment and those specific modalities in use currently for cancer treatments. So there are a lot of words, I think, that are used to describe cancer, so I think it's really good to start off trying to answer the question, what is cancer? So a tumor is a common word. Tumor is a common word that you're going to hear. And this is really defined as an abnormal growth or proliferation of cells. And a tumor can be benign or malignant. So a good example of a benign tumor is a fibroid tumor of the uterus. These are very common in women, and that's just a benign collection of muscle cells in the uterus. Malignant tumors, on the other hand, are those with potential for dysregulated growth and potential for spread in the body. And so the word cancer itself typically implies a malignant tumor with that potential to spread within the body. And cancer can also be referred to as neoplasia. So you'll hear the terms a neoplastic process, and so that is also implying a malignant process. So there are a number of ways that you can think about categorizing tumors, and first is by the site of origin. So sometimes you'll hear tumors described as either solid tumors or liquid tumors. So that's one big separation in terms of types of cancers. And so solid tumors are those that arise from the solid organs. And so the solid tumors, the common examples are breast cancer, lung cancer, colon cancer, prostate cancer, ovarian, thyroid, etc. So all of the solid organs in the body are described as solid tumors. The liquid tumors, on the other hand, are tumors that arise from the blood elements. And so cancers of the leukocytes, or white blood cells, those are described as leukemias. Another form of white blood cell disorder malignant disorders, multiple myeloma, and then a cancer of the lymphocyte is described as a lymphoma. And so we can make that distinction. Overwhelming majority of cancers fall into the solid tumor category. And then if you look at the solid tumors, we can further describe the solid tumors as either carcinomas or sarcomas. So if you look at, again, all of human cancer, the overwhelming majority of human cancers are solid tumors, and they are carcinomas. And so these are tumors that arise from epithelial cells in the body. And so epithelial cells are a very important type of cell, normal cell within the body. They provide the lining to the skin, the internal organs, intestinal tract. And so the carcinoma describes a situation of a cancer arising from those kinds of cells. But there is another type of cell in the body, and these are called mesenchymal cells, and these form a lot of the connective tissue in the body. So the structures and substances that hold our cells together to make the cells form tissues, and sometimes we'll see a cancer that actually arises from this type of connective tissue cell, and those are typically sarcomas. And so, for example, you can have a sarcoma of the bone. The bone is a type of this connective tissue from other tissues like muscle, for example. So this is, as I go through, I'm just going to try to provide examples just to try to emphasize these points. So just using breast cancer as an example, breast tumor, it is a solid tumor. And again, most of these are carcinomas, and they arise from the ducts in the breast or the lobules of the breast. And you can see in the picture on the right of the screen just a diagram of the breast. And I'm not sure if you can see my pointer or not, but the majority of the breast is made of fat, and that's all of the yellow here, but the actual breast tissue, there are the glands, the lobules here in pink on the right of the screen, and then the ducts that basically transport the milk made in the lobule or the gland to open into the nipple. And so you can have a cancer that arises and starts off in the lining of the duct, and that would be a ductal carcinoma. But if it starts off in the milk gland or the lobule, that would be a lobular carcinoma. But very rarely you can have actually primary sarcomas of the breast, and these arise not from the lobules and not from the ducts, but rather from the intervening connective tissue in the breast. And so in terms of the causes of cancer, all cancers are caused by a series of genetic changes within normal cells. And so in all cases, cancer is really a genetic disease. What causes the genetic changes? It varies depending on the situation. These may be due to age. For example, every time your cells divide, they need to do so with really high integrity to make sure that in copying the DNA, there are no mistakes made. And the body is very efficient at doing this, but sometimes mistakes are made that then can propagate as those subsequent cells continue to divide. And so these mistakes can introduce basically mutations in a cell that over time can lead to cancer. And so statistically, as we age, the likelihood that these errors will accumulate in our cells increases. And this is why primarily cancer is a disease of aging. On the other hand, you might have an inherited genetic predisposition to cancer, or you may be exposed to some environmental toxin that predisposes to cancer by causing mutations in your cells. So an example would be someone who is a smoker. We know that tobacco induces genetic mutations in the cells of the normal lung, and that does put that person at increased risk to develop lung cancer. On the other hand, if you look at a woman who inherits a BRCA1 or BRCA2 mutation, this is a genetic change that is inherited, and it's present from birth. And so that predisposition is with that woman from the time of birth. And so it's different in terms of the timing with these different causes, but ultimately the end result is the same, and genetic changes accumulate in the cells that ultimately lead down the path to cancer formation. And so if you look at a normal tissue, so a tissue is basically comprised of cells and the connective tissue that holds those cells together. And so on the left you can see the normal situation. All of the cells are very uniform in size and shape. And over time, as these genetic changes, mutations accumulate in the cells, you can start to see changes that occur. So many times a normal tissue will change in that the number of cells start to build up, and the cells crowd one another, become too numerous, and this is a situation known as hyperplasia, so an increase in the number of cells. And then over time, additional genetic changes can accumulate that starts to make those cells atypical. So they're not yet cancerous, but they're atypical, and this is referred to as atypia or to dysplasia. And then again, as things progress further, the cells can actually become cancerous, but if they are all within the site that they originated, that is a situation that we describe as carcinoma in situ. So it is confined to the place of origin, and so is non-invasive, but then with time you can develop an invasive cancer, and the cells start to lose their cohesiveness, and they start to gain the ability to separate from the rest of the tissue, and they can start to become invasive and spread within the organ where the tumor started, but then also gain access to the bloodstream and to lymph channels and potentially spread within the body. So if you look at the hereditary cancer syndromes, there are many cancer syndromes that have been well described in terms of the underlying genetic change responsible for that syndrome. This is not by any means a comprehensive list, but lists some of the more common hereditary cancer syndromes. So of course the one that's most relevant to our discussion today is the breast and ovarian cancer syndrome caused by inherited changes in BRCA1 and BRCA2. But there are similarly hereditary cancer syndromes that predispose patients and families to colon cancer, and you can see one of the more common ones is this HNPCC, so hereditary non-polyposis colon cancer, and there's other colon cancer and polyposis syndromes like familial adenomatous polyposis, Cowden's disease, which is also associated with colon cancer. We have also described other inherited changes predisposing to pancreas and gastric cancer, and they're listed here. And then there is a common a syndrome called the Frauenmini syndrome that predisposes to multiple common cancers and is very penetrant in terms of the number of affected individuals ultimately developing cancer in their lifetime, and these can be of various types. So if you look at hereditary breast and ovarian cancer, we know that most hereditary breast and ovarian cancers are due to inherited changes in BRCA1 and 2. But if you look overall at the breakdown, you can see that the majority of breast and ovarian cancers actually are what we would call sporadic. So they lack a clear inherited risk factor. So the woman wasn't born with a predisposition, but over her lifetime, she had changes in the tissue of her breast or her ovaries from a variety of reasons that led to accumulation of genetic mutation and ultimately cancer. And so we describe that as sporadic cancer, and that's the overwhelming majority of cancers of the breast and ovary. And so if you look at a sporadic cancer compared to a hereditary cancer, you can see how the development of cancer varies in each of the different situations. And this does have implications for the timing that we see the cancer develop, whether it's early onset or later in life, as well as the overall likelihood that a cancer will develop in that person. So in a non-hereditary situation, a woman, for example, is born and she has no changes in her genes. So you can see this is just an example of two normal copies of a gene on the left. And you can see that over time in her life, depending on her exposures, and again, sometimes it's just a statistical issue with age, that changes can develop in those cells that over time, those two normal copies of that gene, one of them can start to become abnormal and actually lose function. So the woman is then left with one normal copy, functional copy of that gene, and then again with time, as additional changes happen, that normal copy can be lost, and that leads to a situation where the absence of that gene can predispose to cancer. On the right side, though, in the hereditary situation, it's much different. So this is a situation where, for example, a woman inherits from her mother or father one abnormal copy of a gene. And so it's present from birth, and that woman is normal in every way in terms of her development and all of the normal functions that her cells will do. But with time, the cells are reliant on that one normal copy of the gene to maintain order within the cells and to avoid accumulation of excess mutations. But if that normal copy is lost, then you can have a situation again where the function of that gene is lost, and that predisposes to cancer. So in a normal, in a non-hereditary situation, there needs to be sequential hits that knock out one gene copy and then the other gene copy. But in hereditary situation, the cancers are typically seen earlier in life and more likely to see cancers, the potential for having multiple cancers in one individual, and that's because it takes fewer genetic changes to lead to the situation where you have complete loss of function of that gene. So a lot of people are also interested in thinking about environmental risk factors, and there are really a lot of environmental risk factors that can predispose to various types of cancer. Probably the number one most implicated risk factor in our society that we're exposed to is tobacco smoking. So we know that that is a risk factor for a number of cancers, and primarily causes lung cancer. Head and neck cancers are also predisposed in patients who are smokers, also those who consume increased amounts of alcohol. But actually, certain head and neck cancers can actually be associated, their development can be associated with a virus, so the human papillomavirus, or HPV. The same is true for lymphomas. So we know that individuals with HIV infection, for example, they're much more likely to have development of specific types of cancers, primarily lymphoma. They're also predisposed to cervical cancers, for example. The Epstein-Barr virus has been implicated as well, very clearly in the development of lymphoma. And then in cervical cancer, a very common cause of cervical cancer, again, is the human papillomavirus. You can see in breast cancer, they're one of the big risk factors and exposures that women may come into contact with in their life is estrogen, and so that can be both endogenous estrogens, but also women who take estrogens as hormone replacement therapy after menopause for prolonged periods. Alcohol and obesity have also been implicated to increase breast cancer risk. And then, of course, skin cancers like melanoma, the big environmental risk factor there is UV sunlight exposure. So this, again, is not an exhaustive list, but just shows some of the common cancers and all of the different types of risk factors that can predispose. So this is, again, just looking at an example of breast cancer, and you can see this is really quite a long list. These are all factors that have been implicated to contribute to breast cancer risk. On the left, we know, for example, that breast cancer, of course, is much more common in women than men. It is a disease that becomes more common with age. So when a woman becomes postmenopausal over age 50, that's where we start to see rise of breast cancer incidence. We know that those women who inherited a mutation in BRCA1 or 2 or some other high-risk gene mutation like a P53 mutation, they also have elevated risk. And then there are a number of other factors like patients who receive therapeutic radiation for another condition at a young age and had the breast tissue radiated. That's predisposes to future breast cancer. Even in the absence of an identifiable mutation in BRCA1 or 2 or one of the other high-risk mutations, we know that there are certainly families out there that have a lot of breast cancer, and we can't find a clear reason for the cluster of breast cancer in the family. So family history is, even in the absence of a BRCA1 or 2 mutation, is an important risk factor for breast cancer. There are a number of pre-malignant lesions that one can see on breast biopsies. We talked about how the normal cells can become hyperplastic and then atypical and then develop into carcinoma in situ and into invasive cancer. Well, finding one of these lesions like hyperplasia or atypical hyperplasia on a breast biopsy, that is also associated with elevated breast cancer risk. There are a number of features as well in terms of breast density with mammography, and then a number of hormonal factors. So we know that women who have never had a child have a slightly increased risk of breast cancer, and those who've had their first live birth at an age over 30 years, women who take postmenopausal hormone therapy, all of these reproductive and estrogen-related risk factors do predispose as well. And the same is true for the the lifetime exposure of estrogen, endogenous estrogen. So for women who have menarche or have their menstrual period start at a really young age and menopause at a very late age, those women have increased risk for breast cancer because they have longer periods of exposure to estrogen in their lifetime. So you can see that this is really quite a list, and this is, many other cancers will have certainly long lists of risk factors with that may be more or less common in the general population. So if you look at the overall number of cancer cases, this is from estimates from the U.S. in 2011. I think it's always important to recognize and to know what the most common cancers are for both men and women. So this relates to frequency or the incidence of cancer, so how many cancers in this year are being diagnosed. And you can see that cancer is slightly more common in men than women, just over 800,000 cases in men and 774,000 in women. And the three big cancers in terms of incidence in men are prostate, lung cancer, and then colorectal cancer. In women, the big three, number one is breast cancer, and then number two, lung cancer, number three, colorectal cancer. So those are really the primary cancers, and you can see that there are a number of other types of cancer that are much less frequent. For women, about 3% of all new cancer cases are diagnoses of ovarian cancer. If you look at the same data, but this time rather than looking at the number of cases diagnosed and look at the number of cancer deaths in 2011, again, you can see that the number of cancer deaths in men slightly outnumbers those in women, so about 300,000 deaths per year in the U.S. From cancer in men and around 270,000 in women. The primary, three big cancers for men and the three big cancers for women are still at the top of the charts here, but you can see that where prostate cancer was more common, lung cancer is certainly more deadly in men, and in women, again, where breast cancer is more common, lung cancer is certainly more deadly in women as well. So lung cancer is the number one cause of cancer death in both men and women, and you can see that in terms of all cancer deaths in women, about 15% of those are attributed to breast cancer, so that equals about just over 40,000 cases, deaths from breast cancer every year in the U.S. And you can see that ovarian cancer, again, while it makes up only 3% of cancers overall, it does account for a higher number of cancer deaths, still in the single digits, but estimated to be about 6%. So when you look at these data and you start to dissect it a little bit more, and this is, again, just an example with breast cancer, what we clearly know from these type of data is that breast cancer incidence, for example, does vary by race and ethnicity. So there are different risks depending on the racial ethnic group of the woman. And what you can see here is that in terms of breast cancer, looking at going from 1975 up to 2004, you can see that women, white women in the U.S. Have the highest rates of new cancer diagnosis. And second is African American women. And we have much lower incidence rates for Hispanic Latino women, American Indian, Alaska Natives, and then Asian American and Pacific Islanders. And the same is true, if you look at rates of death from breast cancer by race and ethnicity. You can see, again, disparities here. So if you remember the last slide, I said that white women in the U.S. are much more likely to have a diagnosis of cancer than African American women of breast cancer. But you can see that African American women are certainly much more likely to die of breast cancer compared to white women, and they have the highest rates, African American women, of death from breast cancer of all ethnic and racial groups. And so I think that these data, as you go deeper and look into the different incidence rates for each cancer type, you'll see similar trends like this, that there are differences in terms of incidence as well as mortality depending on the ethnic and racial group. So if we move on and think about diagnosis of cancer, cancer can be diagnosed in both symptomatic and asymptomatic patients. So a symptomatic patient, for example, may come in to his or her doctor with a complaint of blood in the stool, with evidence of intestinal bleeding. They may have lab work done that shows an iron deficiency anemia, and the physician may recommend a colonoscopy because of these symptoms that might reveal a colon cancer. On the other hand, you can have a situation where a person comes in for a routine physical and just turned 50 years of age, and so the primary care doctor recommends a colonoscopy for screening for colon cancer, and a colon cancer could be detected in that setting where the patient felt well and had no symptoms of all of an underlying cancer. So in oncology, it's always important to remember that tissue is the issue, and any suspected cancer absolutely must be confirmed with pathologic tissue diagnosis. You can't take some findings on imaging studies on a CAT scan or something like that that are concerning for cancer and assume that this is cancer and treat it as such. We always need to confirm the suspicion with a pathologic tissue diagnosis. And so this allows for assessment of the cell type of origin, and it does allow some additional very important diagnostic testing on that tissue, on the tumor sample, that may have very important implications for treatment and prognosis. So again, with an example from breast cancer, only by getting a biopsy and looking at it under the microscope will you be able to know if a breast cancer is invasive or non-invasive, whether it's ductal or lobular, etc. So it's really important that all cancers, suspected cancers, be confirmed with a tissue diagnosis. And this pathologic diagnosis for solid cancers can be obtained by needle biopsy or surgical excision, and for the liquid tumors, most of the time it can just be determined off of the blood sample because these cells will often be circulating, and sometimes that can be made from a biopsy of the bone marrow, so bone marrow biopsy for the liquid cancers. So after a tissue diagnosis of a cancer is confirmed, then the first thing that needs to be determined is what the stage of the cancer is, and this refers to the extent of the cancer that's in the body. And so we want to know, is the tumor localized, has it spread to lymph nodes, or has it spread to other parts of the body? And so the staging procedures that are recommended can be either surgical or radiographic, so they may be chest x-rays, CAT scans, or PET scans. And so if you think about an example of lung cancer, there may be a situation where a patient has a mass detected in the lung. It gets biopsied and it shows a cancer of the lung. And one of the questions is always, well, did it spread to the lymph nodes in the chest or not? And so sometimes this degree of regional lymph node involvement may be assessed with a surgical procedure called called a mediastinoscopy, where the surgeon will go in with a camera, look around the lymph nodes, and sample multiple lymph nodes in the chest. And that's done for staging. But on the other hand, if the doctors want to see if there's been spread of that lung cancer to any other organs in the body, then CAT scans and or PET scans may be used, and often MRI scans of the brain are ordered for lung cancer to make sure that there hasn't been any spread of the cancer to the brain. And so the type of staging procedure is really dictated by the type of cancer. It's going to be different for lung cancer than it is for breast cancer, than it is for ovarian cancer. And the staging, what is appropriate in terms of staging, is really known by taking into account all that we know about common patterns of spread of different tumors. So this is an example of a patient who presented with a mass in the breast. And that was biopsied. You can see the color photo below. This is the magnified view of what that tumor looked like under the microscope. And this is a brown stain that is staining for a proliferation marker in abnormal cancer cells. And you can see that it's staining very strongly. And so this was a very high-grade and aggressive breast cancer. And then you can see her PET scan on the right of your screen, and this shows multiple areas of cancer spread in the body, in the chest, in the liver, in the bone. And so this was her initial diagnostic evaluation and staging. This is, again, not common to be diagnosed with breast cancer at stage 4. Certainly that can happen. Depending on the type of cancer, the likelihood of being diagnosed at an early stage versus a more advanced stage is really very different depending on the type of cancer. So in terms of staging, it's important to know that the AJCC, or American Joint Committee on Cancer, publishes a manual with all of the most up-to-date information on staging for specific cancer types. This is reviewed by experts every several years with updates published regularly. So sometimes you'll refer to a patient who has breast cancer, and it's AJCC stage 2 or stage 3. And that just refers to this standard staging algorithm that's published. Most of the solid cancers, they have 4 stages, and so this is true in breast cancer and lung cancer, colon cancer, prostate cancer, for example. Non-invasive or in situ cancers, they're typically staged as stage 0. So a ductal carcinoma in situ of the breast. So it's a cancer within the duct that hasn't broken through the wall of the duct, that is staged as stage 0 breast cancer. Stage 4 cancers are typically referred to as advanced cancers, metastatic cancers. All of these things imply the same thing, advanced stage of the cancer. And an example is a breast cancer patient, for example, that has spread of her cancer to the liver. Many times it's often confusing, to patients and their families. Well, do I have liver cancer now, or is it breast cancer? And when the cancer gets into the bloodstream and does spread in the body, and if it does establish itself in the liver and start to grow there, then it's actually breast cancer cells in the liver. And so the way we refer to that is breast cancer metastatic to the liver. And so it may be the same, breast cancer metastatic to the bone, or breast cancer metastatic to the lung. It's not lung cancer or bone cancer. So if you, in this case, if you said that, she has liver cancer, that would, to me, imply that she has a primary tumor that actually originated in her liver cells. So that is a hepatoma or hepatocellular carcinoma, and so that's very different than breast cancer that's spread to her liver. So this is an example in terms of staging for breast cancer. Again, you can see that there are 4 stages of breast cancer, invasive breast cancer, stage 0 being non-invasive, and it's really, there are a number of factors that are looked at: the size of the tumor in the breast, and then the extent of regional lymph node involvement. And stage 4, of course, being distant spread to other organs. And so I think it's important to recognize that staging, it certainly has very important implications for prognosis as well as treatment. And unfortunately, at this time, most stage 4 solid tumors are incurable. There are exceptions in terms of the solid tumors. Testicular cancer, for example, is potentially and highly curable even when it has spread to distant places in the body. Occasionally, immunotherapy can be very effective with complete remissions and cures of melanoma. And sometimes colon cancers can be cured even when metastatic to the liver. For the liquid tumors, lymphomas, for example, they can certainly they're certainly curable at stage 4. Survival with cancer is typically inversely related to the stage. So the higher the stage, the poorer the prognosis. For example, you may have a breast cancer. Most breast cancers are diagnosed at early stages and are curable. On the other hand, if you look at ovarian cancer, this is infrequently diagnosed at stage 1 or 2, and as such, it's associated with poor prognosis. I'm going to just skip this lower part here because I'm going to come to it a little bit later. And so this is just, again, an example of breast cancer showing the inverse relationship between 10-year survival and the stage of the breast cancer. So metastatic cancer refers to cells that are derived from malignant tumors that break off from that tumor and spread or metastasize to other parts of the body. And they do this by traveling through the bloodstream or through the lymphatics. These cells, they can seed other organs and begin to grow there and actually form new tumors at these distant sites. This is, again, typically denoted as stage 4. And when these tumors really get established at distant site, they're very difficult to treat. And so this is why most metastatic cancers are incurable. But again, there are always exceptions, and so it's important to know that that's not always the case, depending on the type of disease. So treatments for cancer, they really vary based on the type of cancer and the stage of the disease. And it's important when thinking about a treatment plan to know whether that treatment is being done with a curative intent, so to completely rid that patient from that cancer and to have a long-term cure, or when cure is not possible, the treatment is then palliative in nature. And so for cancers that are unable to be cured, the goal is really to try to palliate or control the symptoms as long as possible. Many times, cancer treatments are multimodality, and that just means that they're given in combination, and they can be broadly separated into 2 categories, either local therapies or what we describe as systemic therapies, and I'll come back and describe what I mean by that. So local therapies basically remove or destroy cancer cells in one part of the body. And so an example, the 2 big examples of local therapies are surgery to remove a tumor, or radiation that can be given to a localized area in the body designed to shrink or destroy a tumor. Systemic therapy, on the other hand, is treatment or therapy that delivers drugs or some kind of other anti-cancer substance throughout the body through the bloodstream. And so the medicine is then delivered systemically and reaches all parts of the body where the blood flow goes. These types of treatments, they may be given intravenously or IV through the bloodstream, or they may be in pill forms. And they have there are various types of systemic therapies, and they include classic chemotherapy, but also biologic therapies and hormone therapies. So this is an example, again, with breast cancer treatment. If there's a patient with stage 2 breast cancer, her treatment is almost always going to be multimodality. She will have recommendations for local therapy, so surgery to either remove the breast or the tumor in the breast, a mastectomy or a lumpectomy, and then radiation may or may not be given. It's always given after a lumpectomy and oftentimes given after a mastectomy as well. But we know that if we had a woman with stage 2 breast cancer and we just provided local therapy, that if you followed these women long-term, a large group of stage 2 breast cancer patients, there's going to be a number of those women who will down the road in the future develop recurrent breast cancer in other parts of the body. So even when the cancer is localized, there's concern that there may be microscopic spread of cancer cells in the bloodstream or the lymphatics, and this places the patient at increased risk for the future in terms of recurrence. And this is the reason why even when the tumor has been completely removed, that often women with breast cancer are given recommendations for adjuvant therapy. So these are additional therapies given to treat the body so that these small microscopic cells are killed off before they are able to establish themselves in the bone, in the liver, or the lung. So these adjuvant therapies can take many forms. The common ones for breast cancer are chemotherapy and hormone therapy. So for patients who have operable tumors, the surgeon will often remove the primary cancer and a margin of normal tissue around the tumor. And the goal of removing the cancer is to prevent it from progressing locally, but it also helps to remove that source of potentially metastatic cells. And so in patients with stage 4 cancer, many times the primary tumor is not resected since there is cancer in multiple areas of the body, and it's not possible to remove all of those areas to render that patient disease-free. So oftentimes in stage 4 cancer, when there are multiple sites of disease, surgery and local therapies have less importance, and the systemic therapies that again go throughout the body are much more relied upon. There are again always exceptions, and so one example is in kidney cancer. The kidney, even in stage 4 kidney cancers, often removed, and that is associated with better survival in kidney cancer patients. And again, I mentioned before that there actually are some stage 4 colon cancer patients who have disease only that has spread to their liver, and so these patients may be curable over the long term, and so the surgeons will often be aggressive with these patients, resect both the primary tumor in the colon as well as the metastatic tumors that are in the liver. And so for each different type of cancer, the approaches may be different based on what the likelihood is of having different outcome in terms of whether there's potential for prolongation of survival or some other benefit by doing surgery even in stage 4 disease. So radiation refers to the use of high-energy X-rays, and these X-rays are designed to kill cancer cells. These can be used both in the curative setting but also in the palliative setting. So in the curative setting, an example would be that stage 2 breast cancer patient who had a lumpectomy. It is standard to follow that up with radiation therapy, and that is given, again, with her other treatments with a curative intent. You might, on the other hand, have a patient with metastatic breast cancer to the bone who's having severe pain in the bone. And if it's in a specific location, say, for example, in the hip, radiation therapy may be given as a local treatment to that to try to relieve pain and prevent any risk of fracture. So that can be given in a palliative setting. There are different ways to give radiation. The most common way is external beam radiation, and this refers to a treatment where the X-rays originate in a machine outside of the body, and then they're specifically directed at the target, the cancer target, to be treated. But there is another type of radiation referred to as brachytherapy, and this is where radioactive materials are placed in little metal seeds or needles or tubes and are actually placed inside the body at or near the tumor site. So brachytherapy, for example, is used not uncommonly to treat prostate cancer, but it is used in other situations. Breast cancer, for example, there are some external beam techniques are much more used to treat the breast, but there are certainly types of brachytherapy that are in current clinical use. And so radiation is not without toxicity. Certainly it offers benefits to patients in various settings with various types of cancer. And the toxicity really depends on the site being treated, how large the field is, the size of the area being treated, and then the actual dose of radiation delivered. So, for example, a bone, radiation to a bone site is typically very well tolerated, where radiating something in the abdomen near the intestine, that's typically much more toxic, and the tissues of the abdomen don't tolerate the effects of radiation as well as the bone, for example. So the side effects, just when thinking about them, they can be acute, meaning that they can happen right after, during, or right after completion of the radiation, but sometimes these effects can be long-term. So a patient, for example, who has lung cancer that spread to the brain, radiation to treat that in the brain can certainly cause, in the short term, hair loss, but potentially over the long term, cognitive dysfunction, and that can be increased with increasing age. So they may have some more tendency towards dementia and cognitive problems in the future. For patients who get breast radiation for breast cancer, this often causes a sunburn of the skin in the short term. And if you look at some of the late effects of radiation, so long-term survivors of Hodgkin's disease, for example, we know that Hodgkin's disease in the past, and certainly still, radiotherapy was and is a part of the treatment of that disease, and many patients have radiation to the chest area because many times the Hodgkin's lymphoma nodal areas are in the chest. But when a young woman, for example, is radiated in that way as a young person, later in life she's certainly going to be at increased risk for heart disease due to the damage of the radiation on her heart, lung cancer. Certainly these patients are at increased risk for breast cancer, thyroid diseases. All of the organs that are radiated, they do sustain some injury that later in life can cause a problem like those listed here. Skin cancers as well in the field where the radiation is delivered. So chemotherapy, I think most people are familiar with chemotherapy, and this just refers to the delivery of medicines various types that are designed to kill cancer cells. So there are many, many types of chemotherapy, and they have very widely varying side effect profiles. Chemotherapy can be oral or, again, intravenous, but whether they're given oral or IV, in both cases, they enter the bloodstream and they can affect cancer cells all over the body. On occasion, chemotherapy can be actually given into specific body compartments. So in ovarian cancer, for example, you can have chemotherapy instilled into the peritoneal cavity or into the abdominal cavity. And sometimes when cancer has spread to the spinal fluid and the nervous system, chemotherapy can actually be administered and delivered directly into that space, into the spinal fluid. So there are many different ways of giving chemotherapy. Chemotherapy is typically given in cycles, and the drugs are given for 1 or more days, and then there's always a rest period, and this is needed to allow recovery of the normal cells. So chemotherapy typically will target rapidly dividing cells, so that's how it targets the cancer, but there are other rapidly dividing cells in the body, like the hair follicle, like the blood counts, like the lining of the intestinal tract, for example, and these tissues need to recover before additional chemotherapy can be given. So if you look at the common side effects, hair loss is common, but doesn't happen in all cases. It really depends on the specific drug being used. Blood count lowering is a big toxicity of chemotherapy. So this refers to declines in the red blood cells that carry our oxygen around, our white blood cells or infection-fighting cells, and then our platelets, which help us to stop any bleeding if we cut ourselves, for example. So all of these are very much affected by chemotherapy, as is the entire intestinal tract. So the lining of the mouth, the esophagus, the stomach, the intestines, all the way down. This is a very fragile lining, and so this can be inflamed with chemotherapy and can cause problems like mouth sores, irritation of the esophagus, and heartburn symptoms, nausea, diarrhea, etc. Often, because of the blood count lowering effects, many patients on chemotherapy will report and develop symptoms of fatigue. So this is not an exhaustive list, but these are, again, some of the more common side effects of chemotherapy. I wanted to talk a little bit about immune therapy. So this refers to a type of biologic therapy. So these are some of our newer treatments that are coming down the pike. And immune therapies utilize the body's own immune system to try to fight cancer. And so these types of therapies may take the form of therapeutic antibodies that are directed against cancer cells, or more recently, vaccines that try to teach the body's own immune system how to attack the cancer. And so common antibodies, the antibody-based treatments have been available for quite some time now and are well established for multiple tumors. The early one was rituximab or Rituxan to treat lymphoma, but certainly I'm sure most of you are familiar that trastuzumab or Herceptin has really made a big impact in HER2-positive breast cancer, and then bevacizumab or Avastin is another type of antibody treatment used for the treatment of multiple cancers, and of course it has been studied quite extensively in breast cancer and ovarian cancer. So there are other types of immune therapies that are very interesting that you're probably going to hear more about as things move forward. But some of these new approaches actually link a chemotherapy drug to an antibody. And the idea is that this allows for more specific delivery of that drug to the cancer. And so these are antibody-drug conjugates. And we recently saw the FDA approval in the last year and a half or so of brentuximab, which was approved in the treatment of lymphoma. So this was an antibody-drug conjugate. And a very important one that's currently being studied in breast cancer is TDM1. And so this is using the Herceptin antibody, and it's actually being linked to a chemotherapy drug called DM1. So this has been a very exciting drug in breast cancer, and I anticipate will probably be FDA approved in the near future. Cancer vaccines are very interesting as well. They've been primarily used in terms of prevention. So cancer vaccines, these may prevent infections with cancer-causing viruses in addition to potentially treating cancers that are existing already. So one very good example of how vaccines can be used in cancer is hepatitis B virus vaccine. So we know that hepatitis B virus can cause chronic infection in certain individuals, and it very clearly predisposes those individuals to liver cancer. So a lot of the initiative out there to vaccinate people for hepatitis B really is to try and eradicate this infection and this virus and to decrease all of the incidence and mortality from liver cancer caused by hepatitis B infection. But cancer vaccines are also very interestingly being developed to try to treat established cancer. And the idea is just like a vaccine against bacteria, say pneumococcal pneumonia, the normal vaccines that we use for bacterial pathogens, it takes some protein from that pathogen, we get injected with it, and then our body makes antibodies against that protein so that if we ever see that protein in our body, those antibodies will come and attack that bacteria. So the idea here is that proteins, this time from the cancer cells rather than from the microorganism, they are isolated and then they're used to immunize cancer patients against those proteins. And the hope is that this will stimulate an immune reaction, that the body will make antibodies against those proteins, and that those antibodies will then recognize the cancer cells and kill those cancer cells. And so vaccines, there's been a lot of enthusiasm. They are not easy to develop, and the goal is really to try to seek a target that is specific to the tumor, and it has to be distinct from self-protein. So you want to find some characteristic that's specific to the tumor that's not present in the normal cells of the body, and then vaccinate the patient against that specific cancer-related protein. So there was a recent approval by the FDA of Provenge, which is a vaccine used now to treat hormone-refractory prostate cancer. So I think in the future we're going to see many more of these initiatives and development and research into the use of cancer vaccines for a number of different tumor types. Hormone therapies are very important systemic therapies, and this is because some cancers are stimulated by hormones. And for example, certain breast cancers, they can be stimulated by estrogen. Prostate cancer may be stimulated by testosterone. And these are, of course, important. And many of the treatments, the hormonal therapies, actually try to exploit this stimulation. And so it's hormonal therapy. We also refer to it as endocrine therapy, and basically it blocks the effects of hormones on cancer cells. Hormone therapies are generally very well tolerated, much more in terms of comparing hormonal therapies to chemotherapy. For example, the toxicities are less, but still there are side effects associated with all of these therapies, and hormonal therapies may cause weight gain. hot flashes. For women, there may be changes in fertility, changes in the menstrual cycle. For men, impotence by depleting testosterone, for example, to treat prostate cancer. And so I just wanted to go through a quick example of breast cancer treatment and thinking a little bit about markers that are used for all invasive breast cancers that help us to guide what treatments we should be selecting for our patients. So estrogen and progesterone receptors, they are present in the normal breast. And so when a breast cancer develops, that cancer may or may not retain those receptors. And so if you look at all breast cancers overall, about 2/3 of them will retain these estrogen and progesterone receptors and therefore retain the ability to respond to the female hormones estrogen and progesterone. HER2 is another important marker in breast cancer. It's a protein, again, present in the normal breast, but in about 20 to 25% of breast cancers, this protein is vastly overproduced, and it confers a more aggressive behavior in that cancer. So we use these three markers in breast cancer, ER and PR and HER2, to help guide our treatment selection. And so, for example, hormonal therapy is always certainly recommended for breast cancers that express ER and or PR. So that's the estrogen receptor and or the progesterone receptor. And those examples of hormone therapies for breast cancer would be tamoxifen or aromatase inhibitors in postmenopausal women. And then Herceptin or trastuzumab is recommended for all breast cancers that overproduce HER2. So it's not recommended for the other 75% of breast cancers that have the normal amount of HER2, but is reserved for those patients specifically that have cancers overproducing HER2. So I wanted to just talk a little bit about targeted therapy, and there's a lot of overlap with these terms, biologic therapy, targeted therapy. But targeted therapies are medicines that, again, block the growth of cancer cells, and they do this by interfering with very specific molecules needed for tumor growth, rather than, in the case with traditional chemotherapy, just interfering with rapidly dividing cells. So they're trying to target some molecular underpinning in that cancer specifically, rather than just targeting it non-specifically with chemotherapy. And the hope has really been that with targeted therapy development, that ultimately our treatments are going to be more effective and hopefully safer and less toxic to our normal cells. And so one of the very early successes in targeted therapy was a drug called Gleevec, or imatinib. And it was discovered that in a specific type of chronic leukemia, CML, there was a specific molecular marker called ABL, that really seemed to be driving this cancer. And so imatinib was a drug that was designed specifically to block that kinase, ABL, and this has really revolutionized the treatment of CML in a very big way. So this was a really profound early success with targeted therapy. And so targeted therapies have just exploded. And so we talked about immune therapies, antibodies being under the umbrella of immune therapies, but these targeted antibodies are also under the umbrella of targeted therapy as well. So targeted therapies include some small molecule inhibitors of specific targets as well as antibodies. And there's a long and growing list. This is just a few examples of some of the FDA-approved targeted therapies right now. So you can see from my list here that in multiple tumor types, these targeted therapies are being approved, studied, and used for treating various types of cancer. I wanted to take a minute and just talk a little bit about complementary and alternative therapy, what that is. and this really refers to treatments that are given along with standard cancer treatments, complementary medicine, where alternative medicine refers to treatments that are used instead of standard cancer treatment. And these complementary and alternative therapies can take a variety of forms, from acupuncture, meditation, healing touch, to the use of various herbal medications, vitamins, or other nutritional supplements. And I think it's just important to know that complementary and alternative therapies, certainly there are patients who feel that they benefit in terms of quality of life and fatigue, all of these things in terms of going through their cancer treatment. But it's important to know, too, that some of these may interfere with standard cancer treatment. And so the big concern always is about specific herbal supplements. These supplements do many times have pharmacologic properties. And we just unfortunately don't know how they may or may not affect the clearance of chemotherapy in the body. But there are certainly examples where there can be interactions with chemotherapy drugs and various herbal supplements, and this may lead to increased toxicity or even much more concerning decreased effectiveness of the chemotherapy. And so dietary supplements right now are not considered drugs by the Food and Drug Administration. And so, unfortunately, because of this designation, we don't know a lot about their safety and potential drug-drug interactions. The few last slides, I just wanted to move from treatment of cancer to the topic briefly of screening for cancer. So the goal here with screening studies are to basically look at patients who are asymptomatic and screen them for underlying cancers that they may not be aware of. And this is with the goal of enabling early detection of cancers. And so screening studies are definitely routinely performed, cancer screening studies. And you can see there are a number of examples of that for breast cancer, mammography and breast MRI, for prostate cancer, the serum PSA, digital rectal exams, for colorectal cancer, sigmoidoscopies and colonoscopies, cervical cancers, of course, the pap smear, and more recently, there's certainly some data suggesting that those at high risk for lung cancer should be screened with CT scans of the chest to enable early detection. And so screening is, of course, incredibly important when it comes to cancer, and certainly cancer screening tests will increase the chance of diagnosing a cancer early, but at the same time, they're not without risks. And so screening studies, for example, they may appear abnormal when there's really no cancer present. And so this is a situation where you have a false positive result. And this, of course, can lead to additional testing and biopsy, duress for the patient going through all of this evaluation, for example. There's also the issue and concern with screening studies that screening may lead to overdiagnosis of cancer. And so overdiagnosis is a situation where a cancer is diagnosed in an individual that would have never been apparent in that person's lifetime. So meaning that they would have died with that cancer in their body, never having known of its existence. But on the other hand, if you diagnose it, then that potentially is actually leading to harm in that patient because treatments are then offered, and again, there's concern about harms through overtreatment. So, a common situation is an elderly woman. When should mammography stop, for example? At what point do you not want to diagnose a stage 1 cancer in an elderly woman, for example, because of the concern that it's overdiagnosis and that it would never have been relevant or apparent in her lifetime, and that now that you make the diagnosis, you have to put her through all of these treatments that can potentially harm her. So there's a lot of debate about over-treatment, over-diagnosis, false positives. These are some of the downsides, common downsides of screening tests. But again, you know, the screening tests are very important and have accounted for a lot of the success we've made in terms of decreasing mortality or death rates from cancer. And with screening also comes prevention, and cancer prevention really refers to trying to take action to lower your risk of developing a cancer in the first place. And so these approaches are varied, but can range from just simple avoidance of substances known to cause cancer, so efforts for smoking cessation. They can relate to changes in diet and lifestyle. For high-risk patients or individuals, it may prevention may take the form of prophylactic surgery to reduce that risk by removing that organ. But then there's also the whole concept of chemoprevention. And so again, this is using some medicine to prevent cancer. So a great example of this is the use of tamoxifen in healthy women who are at high risk of breast cancer. And we know that tamoxifen, it has been shown in randomized studies for women at elevated breast cancer risk that it will certainly decrease their future risk of invasive breast cancer. So there have been many efforts to look at chemopreventative drugs in various cancer types for various patient populations, but it's always really important that with these kinds of studies, the utmost care and caution needs to be exercised and risks and benefits carefully considered, since you're giving treatments with potential toxicity and side effects to otherwise healthy individuals. So they have no cancer yet. They are at elevated risk for cancer, but they have no cancer yet. So this is certainly something for the hereditary breast and ovarian cancer community. Some of these issues relating to prophylactic surgery, chemoprevention, these are important issues that certainly you're going to hear more about. That's all I have. So thank you.
Great, thank you, Dr. Telli. Lisa, are you going to field some questions here?
Yes, actually, before we started, I neglected to mention that there should be on the right-hand side of your screen an area that says chat. If you have any specific questions, you can type them there, and then Dr. Telli will gladly answer a few questions. And of course, if you have questions that you think of afterwards, you're more than welcome to forward those to us, and we will certainly do our best to answer them. So if anybody has anything that they'd like to ask Dr. Telli before we finish this evening, we'll pause for a moment and see if anybody types any questions. And I know it was a rather comprehensive presentation. So,
there were some questions that came in during the presentation under the questions box.
Okay, I
didn't see them either.
I don't see a question box, Jackie, so I'm afraid you may have to read those.
No problem. We got a few questions during the presentation. So, Dr. Telli, the first one is, do all invasive carcinomas begin in situ?
Yeah, so that's a good question, and the quick answer is no. Many times, it again depends on you know, the origin of the cancer. So, for example, if you look at breast cancer, where certainly there is an in situ form of breast cancer that's well described. We think that there are specific types of changes in the breast that may go from, atypia straight into a more invasive type of cancer. But many times, there is this more linear progression through the changes of hyperplasia, atypia, in situ disease, and then invasive disease. That real orderly progression, it holds up probably best with colon cancer, that progression, but it is different for every tumor type, and so not all invasive cancers are going to go through an in situ phase.
Okay. The next one is it still believed that most breast cancer starts in the milk duct in the nipple?
Yeah, so if you remember the slide of the breast, and there was, we talked about how most breast cancers, these are solid tumors, and then within the solid tumors, the most common breast cancers are carcinomas, and they can be either ductal or lobular carcinoma. And so for some reason, and again, it's not entirely clear, but most breast cancers are going to overwhelmingly originate in the ductal tissue of the breast. And so those ducts are actually pretty long in terms of their length. So they extend from the milk gland, so the lobule, all the way out to open up into the nipple. So anywhere along the track of that duct, the cancer can develop there.
Thank you.
But yes, the answer is yes. Most breast cancers are ductal, but they don't necessarily form right at the nipple. They can form anywhere along the length of the duct.
Great. The next question is, I've heard of stages of cancer such as 1B. What do these letters indicate?
Yeah, so if you ever have a chance, and I think it's a good thing to do, to look at the AJCC manual, you'll see that there are lots of substages for each type of cancer. So for example, for breast cancer, there is stage 1, stage 1A, stage 2, and that can be broken down into stage 2A and B. And then stage 3 breast cancer can be broken down into A, B, and C. And so there are all of these sort of subcategories, and it really describes specific locations of lymph nodes, numbers of lymph nodes involved. And so there's some further stratification and the same is true for lung cancer. And so they're really quite detailed. Many times if it's stage 3B versus stage 3A breast cancer, we just say it's stage 3. But yes, it's true that there are further subcategories within the stages. And so I would encourage you, if you're interested, to look at that and get a feel for that. Look at the AJCC manual, and that will go over in all of that detail, the staging for each of the different cancer types.
Thank you. The next question is, if radiation can cause cancer, how does radiation also treat cancer?
Yeah, so that's a good question. So radiation, like we talked about, it is the use of high energy X-rays, and so we know that this type of high energy can cause injury to cells, both normal and cancer cells. But just like with chemotherapy, cancer cells are not normal. And so if you expose a normal cell on one side and a cancer cell on the other side to chemotherapy, that's going to cause an injury to both of those cells, but the normal cell will be able to repair itself, where the cancer cell, it's just so abnormal it can't do that. On the other hand, radiation, it does the same thing. So if you have a normal cell and then a cancer cell, radiation will cause injury to both of those cells, but again, the normal can repair it, and the cancer cell is just unable to repair that injury and dies. And so that's how it's effective at killing cancer. But sometimes in the normal cell fixes itself, so it gets hit with the radiation beam, and there's an injury that occurs. It repairs it, but maybe there are a few things that it didn't repair, and so they will become mutations. The cell didn't die. It pretty much, to a large degree repaired itself, but now it has some mutations that it didn't have before the radiation. And just like, again, we talked about cancer as a genetic disease, and these mutations can then further accumulate over the course of that person's lifetime, and that's why we see, long-term survivors of, various lymphomas who got radiation to the chest at a young age, coming many years later with breast cancers, skin cancers in the radiation field, lung cancers, all of those types of things. So it causes injury to the cells, and in the cancer cell, the hope is it will kill it off. But in the normal cell, sometimes the normal cell can repair, but not 100%. And so some mutations are left behind that down the road, unfortunately, predispose to cancer.
Dr. Telli?
Yeah? Can you hear me?
Yes, I think it just kind of drifted off at the end.
Okay. Okay.
So the next question we have is, does hyperplasia always lead to cancer?
So not necessarily. So the answer is no. So it can. So hyperplasia isn't an atypical situation, or it isn't a malignant situation. What hyperplasia indicates is just an increase in the number of cells. The cells are normal, but there are just too many of them. And so that's what hyperplasia is. And so you can have hyperplasia for all kinds of reasons in different places in the body. And it doesn't always go down that path to develop additional changes and then become atypical and then go on to cancer. But certainly, when you see hyperplasia, it certainly is a risk factor for progression down that path.
Thank you. And just reading through all the questions here. The next one is, what is resection? You mentioned it with colon and liver cancer.
Resection, so basically that's just, resection refers to an excision or just surgical removal of a tumor. So sometimes you'll hear those words, the surgeon removed the tumor, the surgeon excised the tumor, the surgeon resected the tumor. It all means the same thing. The surgeon took the tumor out.
Thank you. Question I have is, in staging, if there is a tumor of the breast and a tumor of the liver, are pathologies done on both to determine if it is stage 4 or 2 separate primary cancers?
Yeah, so that's a great question. And so many times for women who have recurrence and spread of breast cancer, most of the time they'll have, for example, a stage 2 or 3 breast cancer diagnosed and treated, and then many years later, they may be diagnosed with new spots in their liver, and the concern is that it's from breast cancer, but oftentimes it's unclear, and sometimes you will have that situation in the beginning where you can see cancer in many different places and you're not sure if it's related or not. So if you have a suspicion of stage 4 breast cancer, again, the tissue is the issue, And we always will biopsy that because we want to know, we don't want to assume that the woman has stage 4 cancer and tell her that she has no curable option for her breast cancer. We don't want to deprive her of potentially curative therapy and just make assumptions. So we would always, if we're making a diagnosis of gravity, we always want to go ahead and biopsy the suspected metastatic site.